Now it's time to introduce you with the next Endowment Award, and that is Dr. S.S. Badrinath. Dr. Sengamedu Srinivas Badrinath is the Indian founder and chairman emeritus of Shankara Nethralaya Chennai, one of the largest, India's largest charitable eye hospital. He was elected Fellow of National Academy of Medical Sciences. He received Padma Bhushan, which is the third highest civilian award in the Republic of India in 1996. He has also received many other awards, to name a few, Padma Shri and Dr. B.C. Rao Award. And more importantly, he was a guru of ours when he was trained by us. So it's a privilege to introduce this particular Endowment Award. And it's privilege to invite Guruprasad Aichit, who is a senior most vitreoretinal surgeon of North Karnataka with a 39 years experience. He is a head of vitreoretinal services at M.M. Joshi Eye Institute, Hubli. His area of interest is medical and surgical retina, uvea and combined surgeries, and he has performed more than 20,000 vitreoretinal surgeries. 336 presentations at state, national and international meetings, 24 publications in national and international peer-reviewed journal, and he has been an invited faculty for almost all the state conferences within and outside Karnataka. So, welcome Dr. Guruprasad Aichit, and congratulations for getting this Endowment Award. And his lecture title is The Art and Science of Clinical Acumen Building During VR Fellowship. Over to you, sir.
Thank you very much, Dr. Prashant, for that very kind introduction. It's indeed a great honor for me to be giving this lecture in the name of my mentor, Dr. S.S. Badrinath, sir. Clinician, surgeon, mentor, guru, visionary, ophthalmic leader, legend. He was known by many names. Our chief, Dr. S.S. Badrinath, Padma Bhushan, Dr. S.S. Badrinath, we fondly remember him today because whatever we are today is because of him. He has crafted each one of us into someone who can be worthy of service to humanity. Indeed, the saying goes that wherever there is excellence, there is a chip of Shankara Nethralaya. We are indeed proud SNites. SN and Badrinath sir ignited the candle in us with his spark. I am a proud student of Shankara Nethralaya, which has one of the best structured fellowship programs in the country today. Also made us worthy of training others, which we have been doing by following his footsteps. I thank the scientific committee of AIOS for honoring me with this huge honor, this prestigious endowment lecture in the name of the legendary doyen, internationally renowned Dr. S.S. Badrinath sir. I dedicate this honor to him. Most of what I'm going to say today is about my role as a teacher and how I am trying to carry on his legacy. Just a brief background. There are 751 medical colleges, 66 standalone PG institutes recognized by the NMC, but there is lack of uniformity in the standard of training and standard of exit exams. Most students need the additional basic training, and that is what we call fellowship. So my talk is how do I conduct my fellowship program. Before that, a brief introduction about vitreoretinal fellowship and its uniqueness. It is not taught like other specialties in residency and usually needs to be taught from basics during fellowship. Most of the students say that I know nothing about retina and therefore I want to do retina fellowship. I want every student to be a comprehensive ophthalmologist first and then a specialist. This is what I tell all my fellows. You have to be a good pan-ophthalmologist, a good comprehensive ophthalmologist before you become a specialist. So they have to relearn refraction, basic examination skills, slit lamp examination methods, sublination tonometry, gonioscopy, and so on. It needs weeks of practice to master basic examination techniques like indirect ophthalmoscopy and 90-degree examination. And the findings in the vitreous and retina are so subtle, similar, and diverse that it takes long to familiarize even with the common findings. So hard X-rays and Rosen at different levels, The heart X-rays of diabetic retinopathy, the heart X-rays of choroidal disease may seem similar to the novice, and it takes nearly 3 months to familiarize. So also the level of hemorrhages in the fundus, they are unable to find out or know at what level the hemorrhage is. And therefore, in the first month of fellowship, I usually put them in front of the camera, ask them to take pictures and get familiar with the findings and signs. The safety margin for certain steps of surgery is so little that it is very difficult for letting them loose to do the surgery themselves, lest they cause these iatrogenic breaks. And the diagnostic and surgical equipment are prohibitively expensive, and that is what makes vitreoretina a niche field. A good cataract surgeon can mature into a good surgeon in any specialty. That is what I feel, and therefore I encourage them to do cataract surgery. Dissection and suturing is something that is forgotten nowadays. We are all into modern sutureless surgery, and therefore it is very important that we relearn dissection and suturing, and therefore I involve them in cataract surgeries as well. 100+ score of SICS, especially SICS if not FACO, is desirable before entering a VR fellowship. Mass work in a medical college hospital is in one way amazing. It's really amazing how they can handle so much of work. And this versus the style of working of private institutes offering fellowships like SN and Arvind and others and LVP and ours and Shankara. Most fellows are in for a cultural shock because of this disparity. Every institute has its own SOP, and it is the fellow who has to adapt and adopt the various nuances of the center. I hope I have time. I just started. So it's important that they get adjusted, and I usually give them enough time for them to adjust and adapt. One thing that I learned in Shankar Nethralaya is the discipline that they have, that they practice in making drawings, and this I like to enforce on my students as well. Making detailed drawings. By learning drawings, they learn IDEO, they learn color coding, they understand the inverted image, they realize the importance of drawing for pneumatic retinopexy and scleral buckling, which requires very accurate drawings, and draw a plan for the patient and cross-check with seniors. I think this is one thing that I still practice after 37 years after fellowship. Orthodox methods are best. I always tell my students, especially the DNB students, that every case should be examined as if it is an exam case, like taking the history methodically and examining the patient methodically, coming to a provisional diagnosis, coming to discussing the differential diagnosis, and finally making the final diagnosis. So I also tell them that they should be good technicians first. They have to learn to capture the image, just not read the image, just not read the B-scan, but do it themselves, because B-scan is a kinetic test. And then the acquisition protocols and the analysis protocols of FFA, of OCT, they have to know it themselves, and this is best done by doing it themselves. So they have to do the test themselves, they have to get used, or they have to know how to use the equipment. And this is done best by guidance from an imaging expert. Teaching in the OPD, point out every mistake, small or big, in the workup. Call to show a typical clinical symptom or sign, for example, this post-fever retinitis. There should be uniformity in documentation, especially drawings and labeling. Literature search whenever there is a rare case. For example, this is a case of astrocytic hematoma of the optic disc of the optic nerve head, and this is what will make them good in clinics. Why this, if I ask them why is this patient's vision poor, please find out. The first thing that a VR fellow does is to put on the indirect ophthalmoscope and see the fundus. So I emphasize the importance of torchlight examination and slit lamp examination, because these things can be missed. A trab, bleb, a buckle, an infected buckle for that matter. This patient on the left looks totally normal, whereas actually he has an infected buckle, and this can be missed on slit lamp examination if it is not done properly. This patient is actually not improving after good cataract surgery because of this corneal opacity, and therefore a careful slit lamp examination is very, very important in preventing ordering of endless, unnecessary, expensive tests. The no cost and most useful test in ophthalmology is RAPD. And I think there is no excuse for not doing this test. Even no RAPD is important to document, and I penalize my fellows for not doing the test of RAPD. This one test can settle so many doubts and can avoid many expensive investigations. Another examination or set of examinations that have to become routine in retinal practice is to rule out NVI, which is the harbinger of posterior segment disease, and vitreous cells, anterior vitreous cells, which I insist that they should look for. A logbook is very important. In fact, I make it mandatory for them, but unfortunately, thank you. So the chronology of learning, the record of rare cases, reminder of anecdotes, and it adds weight to the CV when they apply for a job after the fellowship. It definitely adds to their CV. So this is very important. And so learning injections, usually after 3 months, I allow them to do the injections. The A, B, C, D, E, F of injections: A for asepsis, B for betadine, C for concentration of the drug, D for distance from the limbus and direction of the needle, E for the exercise of finger counting is something that I insist on, is something that I teach them as an acronym to learn the injections. Learning lasers after 3 to 4 months, I think this is one of the best cases to learn lasers because they cannot do anything to the fovea. An inadvertent foveal burn is not possible in such patients, and these are the right patients to start off, and better done under this guidance of a senior. So this is how laser is being taught. In the second year, they are given a little authority, freedom and independent responsibility. They're posted in the periphery in secondary centers, which many institutes have. They involve in discussions with the consultants. In fact, consultants start taking opinions from them and encourage seniors to teach juniors. They should engage in video editing. This is very important because it gives a sense of involvement in the surgery and better understanding of the surgical steps. So whenever there is time, Chief used to say, Dr. Badrinath sir used to say, if you are free, don't waste time. Go to the theater. If there's something going on, please observe. So this is something that I always tell my DNB students, that they have to come and see if something is going on in the theater to learn more and more. This is no time to be wasted, at least during the first year when they are free. Sorry. So they are encouraged to ask silly questions, however silly it might be, not to be stuck with the basic doubts, because it is very difficult to unlearn wrong concepts. They should build concepts around the right evidence. And I always give them an assignment every day: read this and come, read Mactel and come, read PCV and come, so that they engage themselves in some homework and come back next day to tell me about something. By assessing surgery, they get involved. They're told to see both through the microscope and outside it. A good assistant only can be a good surgeon, is what I believe in. Hands-on surgery is something that they enjoy the most. It gives them the kick. It gives them the maximum satisfaction. And knowing the machines is also very important. Professor Badrinath used to say, Muthu knows better than you. Muthu was one of the OT assistants, and he used to scold us if he didn't know about the foot pedal. He used to scold us saying, Muthu was an OT assistant, a very popular one. He knew everything. He used to guide juniors and fellows. And Dr. Badrinath used to say, go and learn from Muthu. So this is what we should, and in fact we should volunteer. The students should volunteer to help set up the equipment along with the technician. Surgery, just briefly I will tell about surgery. OT etiquette is something that one has to learn, and it has to be taught very meticulously. Asepsis is something that they should never forget. They have to learn surgery in a phased manner, peritomy, rectal tagging. Getting started with SP, they can start with localization of breaks. Trocar cannula insertion, checking the infusion for a clean pass, and core vitrectomy in pseudophakics. PVD induction gives the first big kick, I think this is something which everyone will agree, all the juniors will agree that when they do the PVD induction for the first time, they really feel ecstatic. The students are really very happy, and that is what I think, if you want to please a student or get some work done from him, you should give him a PVD induction to do. Steps in the second year or later half of the fellowship is like ILM peeling and all that. I think this only requires deftness. It does not require much of knowledge or skill. It requires skill but not knowledge. So this is something that we can give in the second year. And complex four-port bimanual surgery towards the completion time. So by the time they're completing, say, by the time it is 2 years or 2.5 years, that is the time when you can give them complex surgeries like this. Community work must be mandatory. It's an opportunity to exercise skills, both clinical and surgical. They are given independent charge, which adds to the confidence because of the volumes that they come across, the number of surgeries, which helps them achieve perfection, and they understand the ground reality of the poor socioeconomic section of society and develop compassion and empathy. There's no endpoint for learning VR surgery, but 50 to 60 independent surgeries, I think, along with 10 complex surgeries in 2 years is something that will give them confidence. This is my, the benchmark. First and foremost, they should really love the specialty. One can't flog an unwilling horse, we all know that, but good mentors can make them fall in love. So he empowered us with the 3 hands. Badrinath sir, the legend, empowered us with the 3 hands, 3 H's, hands, head and heart. His powerful teachings have made sure that we pass on his legacy. He believed that a candle loses nothing when it lights another. Thank you very much for your kind patient listening. And I thank the All India Orthodontic Society for this huge honor. Thank you very much.
Thank you so much, sir. Thank you for that wonderful lecture.